let's jump right into this rapid-fire MCQ explainer on clinical nutrition and surgical access management. We've got a lot of high-yield ground to cover, so let's get started.
Section 1, Nutritional Screening and Fluid Assessment. We'll be focusing on core measurement techniques here.
All right, first question. Which of the following is a simple measure for assessment of the nutritional status of a person? Are we looking at A, serum albumin, B, transferrin, C, mid-arm circumference, D, lymphocyte count, or E, daily weight?
If you guessed A, daily weight, you hit the nail on the head. I know, it sounds almost too simple, right? But tracking daily or baseline body weight remains the absolute simplest, most cost-effective first-line tool we have. It actually serves as the very foundation for validated protocols like MUST. Now, here is a massive example for you. Do not get tricked by biomarkers like albumin and transferrin for basic screening. They are highly misleading because they mostly just reflect acute fluid shifts and systemic inflammation, not your baseline nutrition. Oh, and that lymphocyte count? That's really only assessing immune suppression in cases of advanced starvation.
Okay, moving right along. A patient is planned for total parenteral nutrition, or TPN. Which of these provides the best estimation of body fluid? A, bioelectrical impedance, B, body weight, C, skin fold thickness, D, mid-arm circumference, or E, tagged molecules.
The correct answer here is A, bioelectrical impedance. This is a brilliant, non-invasive clinical tool that measures the resistance of an electrical current flowing through tissues. Think of it this way. Lean tissue and water conduct electricity easily, while body fat basically acts like an insulator. So right before starting TPN, this tool gives us a vastly more precise assessment of true cellular fluid than a standard body weight scale ever could, mostly because a regular scale totally fails to differentiate between temporary fluid retention and actual functional muscle mass. Let's step into the intensive care unit for this next one. Which of the following is the most effective way for assessment of fluid balance in patients admitted to the ICU? Is it A, daily weight, B, pulse, C, fluid intake and urinary output record, D, blood pressure, or E, oral mucosa? The answer is absolutely C, fluid intake and urinary output record. When you're in the ICU, rigorous hourly tracking combined with regular hemodynamic assessment is your most reliable tool to spot developing organ hypoperfusion or an acute kidney injury. So here is your critical takeaway. The absolute second you identify oliguria, your clinical reflex must be to immediately verify that intake and output chart. You need to check those core hemodynamics and figure out fast if you're dealing with intravascular hypovolemia, cardiogenic failure, or intrinsic renal tubular injury. All right, try this one. A middle-aged post-esophagectomy patient lost 12 kilograms and is now receiving enteral nutrition via a jejunostomy. Which is the best means to determine the adequacy of their nutritional support? A, serum albumin, B, transferrin, C, urinary nitrogen, D, total serum protein, or E, respiratory quotient? And the correct answer is A, serum albumin. You see, physiological timelines dictate clinical use here. Albumin has a relatively long half-life, of roughly 21 days. That makes it the gold standard, reliable overview tool for tracking long-term visceral protein synthesis and chronic nutritional status. Contrast that with prealbumin, which has a half-life of under 2 days. That incredibly short half-life makes prealbumin a highly sensitive indicator for tracking short-term changes and early responses to feeding. But for the long haul, we rely on albumin. Let's look at a classic trick scenario. A patient with a 20% mixed thickness burn has fluid resuscitation and enteral nutrition initiated. Which gives the best measure of nutritional support adequacy 10 days after admission? A, daily weight, B, CBC, C, albumin, D, urine output, or E, albumin/globulin ratio? It's C, albumin levels. Now, why is daily weight the wrong answer here? Because massive crystalloid fluid weight completely invalidates daily scale measurements in burn patients. During those first 10 days, aggressive fluid resuscitation easily expands the extracellular compartment by 10 to 20 kilograms. That literally completely masks their underlying muscle wasting. So for your protocol, track calorie counts in BUN daily for acute metabolic demands, but absolutely rely on weekly visceral proteins like albumin, along with CRP to monitor actual structural synthesis. So, thinking about wasting, most nitrogen loss during trauma occurs due to the breakdown of which of the following? A, adipose tissue, B, skeletal muscles,
C, smooth muscles, D, cardiac muscles, or E, none of the above?
The answer is B, skeletal muscles. Severe trauma and sepsis trigger a massive counter-regulatory hormonal surge. This surge specifically targets your peripheral skeletal muscle for profound proteolysis, basically breaking it down to fuel hepatic gluconeogenesis. But crucially, cardiac muscle is spared. It's protected during this catabolic wasting process. And to put the sheer scale of this into perspective, severe sepsis can cause a depletion of up to 20 grams of nitrogen per day. That is the equivalent of wasting 500 grams of functional muscle mass every single day.
Let's pivot to access routing. We have a malnourished 49-year-old esophageal carcinoma patient who is planned for resection. Which is the best means to provide nutrition? A, jejunostomy, B, TPN, C, PEG, D, nasogastric tube, or E, peripheral parenteral nutrition?
Correct answer A, jejunostomy. First rule of thumb, enteral always beats parenteral. Secondly, an esophagectomy essentially eliminates the lower esophageal sphincter. So if you used a pre-pyloric option like a PEG tube, you'd cause severe, uninhibited reflux and likely aspiration. But here is the absolute crucial anatomical pearl. The stomach is required as a mobilizable graft for the future pull-up reconstruction. Placing a PEG tube literally damages that exact stomach wall, creating scar tissue that can completely ruin the reconstruction. That's why a post-pyloric jejunostomy is the gold standard here.
Keep that rapid-fire rhythm going. What is the most appropriate route of nutrition for a patient planned for major upper GI surgery for a corrosive stricture of the esophagus? A, NG feeding, B, open gastrostomy, C, narrow tube jejunostomy, D, TPN, or E, PEG?
The correct choice is C, narrow tube jejunostomy. Caustic ingestions are devastating. They cause intense inflammation and transmural scarring across both the esophagus and the stomach. This kind of regional damage completely rules out any pre-pyloric option. Using a narrow tube jejunostomy brilliantly bypasses that extensively scarred upper GI tract entirely. This provides secure nutrition while meticulously preserving any remaining healthy colon or gastric tissue so it can be used for future reconstructive bypass grafts.
Okay, try the scenario. We have a 44-year-old malnourished male with gastric carcinoma and pyloric stenosis. What is the best way to provide nutrition? A, jejunostomy, B, TPN, C, PEG, D, nasogastric tube, or E, peripheral parenteral nutrition?
Once again, it's A, jejunostomy. The absolute critical puzzle piece here is the mechanical obstruction. Pyloric stenosis completely blocks the outlet. That means any fluid delivered pre-pylorically, like via an NG or PEG tube, will just pool, wildly distend the stomach, and inevitably trigger massive vomiting and aspiration. You have to remember the golden clinical rule of surgical nutrition. Always use the functional GI tract. The small bowel below that obstruction is perfectly fine. Bypassing the stomach with a distal jejunostomy maintains normal absorption while completely avoiding the severe infectious and metabolic risks associated with a long-term central venous TPN line.
What will be the appropriate mode of nutrition in a neurologically disabled patient who is permanently unable to take oral feed? A, nasogastric, B, gastrostomy, C, jejunostomy, D, peripheral PN, or E, total PN?
The correct answer here is B, gastrostomy. For chronic cases like permanent dysphagia where the GI tract is actually intact, a gastrostomy like a PEG tube is the absolute ideal choice for support lasting longer than 4 weeks. Why? Because it utilizes the stomach's natural reservoir capacity. This allows for incredibly convenient bolus feeding, which is so much easier for patients and caregivers compared to the continuous pump infusions that a jejunostomy requires. Also, a quick note, in pediatric cases, this is frequently paired with an anti-reflux fundoplication to prevent aspiration.
All right, let's hit one final biochemical hurdle. Which of the following is a source of fatty acids in total parenteral nutrition? A, canola oil, B, sunflower oil, C, cod liver oil, D, mustard oil, or E, none of the above?
The correct answer is B, sunflower oil. TPN lipid emulsions rely predominantly on either soybean or sunflower oil, and the reason we use these is that they are super rich in long-chain, polyunsaturated fats, specifically the essential linoleic omega-6 acids and alpha-linolenic omega-3 acids. Because the human body literally cannot synthesize these from non-dietary sources, administering these specific lipid emulsions is absolutely mandatory to prevent essential fatty acid deficiency.
Let's lock all of this in with a quick summary table. For short-term fluid tracking, your go-to is daily body weight scales. But remember, this goes completely out the window and becomes unreliable during acute fluid resuscitation, like with our burn patients. For short-term nutrition change, serum prealbumin with its sub-2-day half-life is your marker, though it won't reflect long-term storage. For long-term adequacy, look at serum albumin at roughly 21 days, keeping in mind it can be altered by systemic inflammation. For normal emptying past 4 weeks, select a prepyloric PEG unless you have a contraindication like pyloric stenosis. And finally, for a proximal obstruction, your safest bet is a post-pyloric jejunostomy, which of course requires surgical placement. So next time you're evaluating surgical nutrition, just ask yourself, are you looking at the true metabolic picture, or are you just being fooled by a temporary fluid shift? Thanks for joining me on this rapid-fire explainer.